Thank you everybody for joining in. I already can see there are nearly 60 people here. This is extremely encouraging. What we will do is essentially basically take you through the physiological basis of one lung ventilation, and then uh, possibly then take a break, maybe look at questions, and finally uh, go through the management bit of one lung anesthesia. So, what you see is lung volumes and gas exchange during anesthesia. What we will try and do is take you finally through gas exchange through anesthesia. Okay, so what general anesthesia does to the physiology of breathing, if you want to see, it affects both the static as well as the dynamic behaviors. By the static, we mean the pressure volume relationship, and as well as the dynamic behaviors like the pressure flow behaviors. So that's what general anesthesia does to the physiology of breathing. Uh, Coming to the main thing that anesthesia does is the moment you anesthetized a person who's already supine, the FRC or the functional residual capacity reduces by 15 to 20% of the awake value. Remember, the same change happens the moment a person is erect and then becomes recumbent. The FRC goes down by 15 to 20%. And this recumbent patient, moment you administered a general anesthetic, it reduces by another 15 to 20%. So this is one of the things that GA does, general anesthesia does to the FRC, and especially to somebody obese, because this is related to age and body habitus. Especially in the morbid habits, this decrease can be up to 50% of the pre-anesthetic values. And so this becomes a real bothersome thing. So what general anesthesia does to the physiology of breathing, this is one of them. So what is the reduced FRC's effect on the airway? So at the high lung volumes, the effect is large, and the low lung volume, it is long, and it can change the caliber of the airway. So, and this is in one way a passive change in the airway resistance, which is independent of airway constriction. So FRC can also affect the the dynamic behavior. The general anesthesia, by the reduction in FRC, can change the dynamic behavior of breathing as well. Okay, so when does this happen? It starts in nearly instantaneously. Reduction occurs within a minute after induction. Fortunately, it does not progress with time unless something else also is happening, or you're doing something else by which the FRC can come down. And it is not, it has been seen by most studies, that not affected by further addition of muscle relaxants. So that is why if you want to reduce this, it has to happen quite early. Okay. So why does the FRC decrease under a general anesthetic? If you look at the main, it's a complex mechanism and it's not totally understood. And the possible mechanisms through which it can happen is through atelectasis, increased expiratory muscle activity, which is coming out emptying the thoracic cavity. The trapping of gas in the distal airways is closing, so trapping, so FRC goes down. Cephalate displacement of the diaphragm during general anesthesia, decreased outward chest recoil. Remember, there are two recoils: the thoracic cage. There is an outward chest recoil, where there is an inward recoil of the lung, and there is a decreased outward chest recoil, while there is an increased inward recoil of the lung, which is why again you can have decreased FRC. And there could be any reason wherein there is an increased thoracic blood volume. Classically, when you put them to sleep, the thing that is in the limbs are coming into the thorax, and that is how the thoracic blood volume can go down. So those are the reasons by which the FRC could decrease.